I want to thank the Saudi Society of Blood and Marrow Transplantation for the kind invitation to participate in this year's Congress. My name is Antonio Jimenez, and I'm an associate professor of medicine in the Division of Transplant and Cell Therapy at the University of Miami. Today, we walk through how MRD intersects with transplant decisions in AML, from whether to proceed to transplant to how to manage patients afterwards. And rather than just reviewing the data, I will try to frame this talk around key clinical questions that we face every day. These are my disclosures and conflicts of interest, and I will be discussing the use of an off-label investigational pharmaceutical product. So in ways of background, I think it's important to recognize that I think we all know that now that morphological remission has never been enough, and it really is insufficient to define disease clearance in AML. Measurable residual disease, or MRD, is now established as the strongest independent predictor of relapse and survival across multiple studies. And MRD status is formally incorporated into most current guidelines, including risk-adapted strategies by both the ELN and NCCN. And it's important to remember that MRD not only informs prognosis, but it's really increasingly driving many of our therapeutic decisions both before and after transplant. We can use several platforms clinically. By far the most commonly used one is flow cytometry, and it remains broadly available, but has a lower sensitivity, and we do encounter issues with how to reproduce and operator variability. PCR-based assays, they truly offer much deeper sensitivity for null targets, such as NPM1. But of course, as we all know, it has very limited applicability. NGS, and most recently error-corrected NGS, has expanded applicability, variable sensitivity, but we continue to have challenges around cost and harmonizing assays. Prior to transplant, MRD status informs us of an individual patient's relapse risk. For many patients, can also inform the urgency of the transplant, and for other patients, the choice of conditioning. After transplant, MRD surveillance offers us a window for preemptive or therapeutic interventions. And depending on the context, we can use blood or marrow samples to track disease. And across both settings and pre and post-transplant, MRD really is not just prognostic, but potentially actionable. And I think this is important to remember. And now I want to go through some of the key clinical questions that will shape our talk today. I want to walk through them one by one, trying to focus on where the data is a little bit stronger. Also talk about areas where uncertainty remains, and discuss a little bit how we are adapting in the clinical space for these gray areas. The first question is, are our tools sufficient, and should MRD guide whether or when to proceed to transplant? Can we safely defer transplant when MRD is negative? Can we, and is there a benefit to erase MRD prior to transplant? Can conditioning intensity modify risk based on MRD? How should we monitor after transplant? And when and how should MRD drive our post-transplant interventions? And I want to finish by discussing sometime about the gaps that remain for future studies. So I want to start with our first clinical question, and that is, how should MRD inform risk stratification? And perhaps more importantly, are our current tools good enough to accurately risk stratify patients heading into transplant? And the short answer is not yet. There's a few things we know. MRD clearly informs relapse risk and survival, but it really matters how we measure MRD. So I'll be talking a little bit of the pre-measure study. This was a critical step in showing that traditional flow cytometry often fails to distinguish high-risk patients. And error-corrected NGS can identify patients at substantially higher risk for relapse and death. Even for patients who appear to be in morphologic remission, flow cytometry couldn't really reliably predict outcomes. But I think it's important to remember that the pre-measure study didn't address whether we should delay transplant based on MRD status, and I think that's an important consideration. But what these studies show is that if we're going to use MRD to inform any part of our transplant strategy, whether that's which conditioning or surveillance or post-transplant interventions, we need more precise tools. And I want to show you what that looks like. The pre-measure study was an important step in understanding what was the prognostic value of pre-transplant NGS-based MRD on post-transplant outcomes. This was a multi-center study led by the CIBMTR, looking at patients undergoing first allotransplant in CR1 for AML. All these patients had a remission blood sample collected within 100 days prior to transplant, and the final analysis including a cohort over 1,000 adult patients. We assessed MRD using error-corrected NGS with a gene panel that included NPM1, FLT3-ITD, IDH1 and 2, and KIT. On the left, you can see that relapse rates by MRD status were significantly different. 68% of MRD-positive patients relapsed compared to just 21% of MRD-negative patients. And while I'm not showing that here, that translated into a difference in 3-year survival, 39% versus 63%. Right in the middle, you can see survival based on flow cytometry defined MRD. And this was reported by each individual center. I think it's important to mention that. But as you can tell, the curves are essentially overlapping. And on the right, when MRD was assessed with error-corrected NGS, survival curves separated clearly. And this really highlights why platform sensitivity matters. In this particular study, flow cytometry failed to meaningfully distinguish outcomes, while NGS reliably stratified risk heading into transplant. So to bring this together, I guess the one key message here is MRD is a key prognostic tool before transplant. When we use error-corrected NGS, we can get much sharper stratification compared to traditional flow cytometry. But I think it's important to remember that its application remains limited in routine practice. One caveat is to remember that this data doesn't support transplant timing based on MRD status, and that clinically, the most general strategy continues to be proceed with transplant once remission is achieved for most patients, and I'll discuss that later. But with that said, MRD status still carries major value, and it helps us think about how we can tailor conditioning, how to monitor after transplant, and identify the patients that might benefit from preemptive interventions. But I'll come back to those strategies later in the talk. So now let's move into the next question. Can we safely defer transplant if MRD is negative? Even among patients undergoing allogeneic transplant, MRD negativity does not eliminate relapse risk. So if we see on the pre-measure study, around 20% of patients who were MRD negative still relapse after transplant despite this very highly sensitive error-corrected NGS. And I think it's important to remember or reinforce the fact that MRD negativity reduces risk, but does not guarantee a cure. Many other studies have investigated whether in selected cohorts who achieve MRD negativity, transplant deferral with close monitoring might be a safe strategy. And I want to walk you through that data on the next few slides. Here we can see that several trials support a selective deferral strategy. In the Jimenez AML 1310 trial, MRD negative intermediate risk patients, and these patients were assessed by centralized flow cytometry, received an auto rather than an allo transplant. And these patients achieved a 79% 2-year survival, which was comparable to MRD positive patients receiving an allo. In the SETLAM 12 study, MRD negativity was assessed primarily by quantitative PCR targeting known mutations, or by flow cytometry when necessary. And on patients who remain MRD negative following consolidation and avoided a preemptive transplant strategy, we can see an impressive 91% survival at 2 years. And data from the NCRI AML 17 and 19 trials, looking at patients, these are patients with commutated NPM1 and FLT3-ITD, show that MRD negativity really helped refine the transplant decisions. For these patients, MRD negative patients didn't really derive a clear survival benefit from immediate transplant, even though there was a signal for higher relapse. And this really highlights the need for nuance in transplant decisions. Generally speaking, in favorable risk AML, MRD negativity may allow transplant deferral if we can do close monitoring. But for patients with very high risk features, that's your TP53 patients, complex monosomal karyotype, or other adverse genotypes, MRD negativity doesn't really neutralize relapse risk, and early transplant remains strongly favored, and perhaps really the only way to offer a curative treatment to these patients. Let's now move into the question of whether we should attempt to eradicate MRD before transplant. So one thing we know is MRD positivity pre-transplant is clearly associated with higher relapse rates and lower survival. So it would be intuitively appealing to try to deepen remission before transplantation, but it's important to remember that no prospective trials have shown that delayed transplant to attempt this MRD clearance has any impact on outcomes. And another important thing to remember is we have to be careful about the risk of delaying transplant in someone who's otherwise ready. We have the risk of relapse, clonal evolution, and treatment toxicity, which are all very real. So let's go briefly and review the limited available data for this particular question. Some studies suggest that additional therapy can convert MRD positive patients to MRD negative. One of these studies is the VIALE-A trial. In this study, 41% of patients achieved MRD negativity with a combination of Ven/Aza, although for most cases, prolonged therapy over many cycles was necessary, over 7 cycles, actually. A single center study, this was actually an MSK study, found that in a cohort of over 200 patients, about a third of MRD positive patients converted to MRD negative patients after additional therapy. But this conversion was much more likely on patients with lower risk mutations such as NPM1, CBP8, or KIT, whereas patients with very adverse genotypes or complex karyotypes had really persistent MRD despite additional treatment. We have circumferential evidence that deeper remissions are associated with improved transplant outcomes. One example is the ratified trial. We see here that the addition of midostaurin to chemotherapy improved survival in FLT3 mutated AML, including patients who later underwent transplant. But it's important to know that MRD status was not formally assessed and ratified, so we have to interpret this data carefully. MRD interpretation is heavily confounded also by underlying disease risk, and we also have data from COPR-FT studies, including the ALPHA and HOVON-SAC trials, that show that allotransplant provided protection for relapse and improved survival for both MRD positive and MRD negative patients. So the data is fairly mixed in this regard. Critically speaking, no randomized trial have directly compared MRD-directed therapy versus an immediate transplant strategy. So how do we use that data clinically to make decisions? This is a controversial topic, but my general approach and the approach from many other groups is, in clinical practice today, patients with high-risk genotype, including complex karyotype, TP53, proceed directly to transplant once remission is achieved if a suitable donor is identified, even if MRD persists. Again, particularly with TP53 mutated disease, is a controversial topic, and ideally these patients should be treated, transplant or not, in a clinical trial. In contrast, selected lower risk patients, particularly those with NPM1, CBP8, or targetable mutations like IDH, can be considered for MRD-directed therapy if they're not fit for immediate conditioning. But we have to also remember the risk of delaying transplant, including the risk of over-relapse or clinical deterioration. The real answer here is that we really need large genomically annotated prospective trials to help guide future practice in this particular space. Now that we have discussed MRD status before transplant, another key question that I want to cover is whether transplant conditioning intensity can modify outcomes, particularly for patients with MRD positive disease. We know that MRD positivity clearly predicts worse transplant outcomes, but the role of conditioning intensity remains less clear, and it becomes a question of is less more or is more more. I want to walk through that data, starting first with studies suggesting that intensification might not make a major difference. So several studies suggest that more intensive conditioning does not fully overcome the adverse impact of MRD. One of these studies is the NCRI Figaro trial, and this trial compared an intensified RIC regimen, Flamsaview, to standard RIC in older adults. and really show, as we can see here, no improvement in overall survival or relapse incidence, regardless of conditioning intensity. In a similar way, the NCRI AML 17 trial among patients with NPM1 mutated AML, conditioning intensity had no impact in survival outcomes for MRD positive patients. On the flip side, several studies suggest that intensified conditioning may improve outcomes in MRD positive patients, or more is more. To the left here, a secondary analysis of the 0901 showed that patients with detectable mutations by NGS had significantly lower relapse rates and higher survival if they receive a MAC compared to a RIC conditioning. A retrospective study from the EBMT registry, as not pictured here, found that younger MRD positive patients had higher relapse rates and worse leukemia-free survival when treated with non-intensive conditioning. Here in the middle, we can see that in the pre-measured study, conditioning intensification also improve outcomes in younger MRD positive patients. And even the choice of chemotherapy in reduced intensity appeared to have an impact on MRD. In this particular trial, the use of melphalan containing reduced intensity also correlated with lower relapse rates. And in the Hovon-Sack trials, patients with FLT3-ITD mutated AML and MRD positivity had lower relapse rates and better survival when they received MAC compared to RIC, without an increase in non-relapse mortality. So to summarize here, MRD positivity before transplant is associated with lower outcomes across all conditioning intensities. However, we have growing evidence suggesting that myeloablative conditioning might improve the outcomes in selected MRD positive population, particularly in younger fit patients who can tolerate more intensive regimens. At the end of the day, the choice of conditioning must integrate MRD status, underlying disease risk, and patient-specific fitness. And we do need large prospective trials, specifically stratifying by MRD, to better define optimal transplant conditioning strategies. After transplant, MRD monitoring is crucial. The persistent or reappearance of MRD is strongly correlated with relapse. And while there's no general consensus, at our institution, we generally perform marrow MRD assessment around day 100, and especially for high-risk patients, every 3-4 months for the first year, and every 6 months until year 2. Peripheral blood monitoring is feasible for specific markers like NPM1 or FLT3-ITD, although discordance with marrow results can happen. And I think it's important to remember that surveillance enables early intervention and is essential to optimizing post-transplant outcomes. When MRD persists or reappears after transplant, it generally should drive intervention. Some of our options include accelerated immunosuppression tapering, which is usually the first step, DLI, or when possible, targeted maintenance therapies. It's important to remember that timing is key, and early intervention offers the best chance to prevent over-relapse, which is, of course, much more challenging to treat. And ongoing trials are helping define the optimal approaches for MRD-guided interventions. So what's the current evidence for MRD-guided interventions after transplant? And the short answer is we have very limited prospective data, and most come from retrospective series. Most of these retrospective studies suggest that DLI can achieve meaningful responses in the setting of molecular relapse. We also know that maintenance therapies like gilteritinib in FLT3 mutated AML can have survival benefits. While the phase 3 Morpho trial showed no difference in relapse-free survival, there was a pre-specified group analysis that showed a benefit in patients with detectable MRD, and these showed reduction in the risk of relapse by approximately 48% compared to placebo. And I think that an important message is that consistent MRD surveillance remains essential to enable preemptive interventions before over-relapse, which is, of course, much more challenging to treat. So what are the current gaps and the potential for future directions? And I think at least some of the few that I consider to be the most important. I think number one, we really need standardization across MRD platforms. Number two, prospective trials linking MRD to specific therapeutic interventions. Number three, understand for how long and when we should be giving maintenance to patients. definitely integrate MRD into transplant eligibility and risk models, and understand a little bit better MRD dynamics post-transplant in different AML subtypes. And many trials, ongoing trials, are shaping the future. In the interest of time, obviously can't include them all, but some of the key studies that I want to discuss very briefly. The MEASURE study by the NMDP, looking to optimize post-transplant relapse detection using a more refined molecular MRD assessments. The Amadeus trial is testing oral azacitidine maintenance. The INTERCEPT platform is randomizing MRD positive patients to interventions versus surveillance. The MILO-MATCH, it's an MRD integrated into multi-platform trial designs. And a little bit of advertising here. It's our own trial at Sylvester. We're looking at a combination of Ben-ASAP plus DLI for high-risk AML after transplant. And the majority of these patients are patients with detectable MRD before or after transplant or very adverse genotypes. So our trial, this is a phase 1 dose finding study targeting patients with very high risk AML. And we define very high risk AML as patients with pre-transplant MRD undergoing reduced intensity or non-ablative allogenic transplant, post-transplant MRD at day 30, irrespective of conditioning intensity, and patients with very adverse genotypes, such as monosomal karyotype or TP53-17P mutated disease. All patients receive a year of treatment with venetoclax with 6 cycles of low-dose azacitidine, and every patient receives a first dose of DLI with additional doses 2 and 3 if there's persistent MRD. We have enrolled 4 patients to date, and I'll be happy to share some of these results in the next year or two once we have them. To summarize, MRD is an essential prognostic tool before and after transplant. It should inform risk-adapted strategies, but really should not delay transplant once remission is achieved. Conditioning intensity and post-transplant interventions can help mitigate MRD-associated risk, and our field is moving very rapidly towards fully MRD-driven therapeutic models. So I think the future is bright. There's still a lot of questions, but a lot of people are doing a lot of good, fine work to try to answer some of these questions. So for the last slide, I want to share how I approach the MRD in clinical practice. And I titled this last slide, MRD Mostly Rational Decisions, because in reality, and being fully transparent, there are a lot of open questions. And I think many of us are still trying to figure out how to use this information better while new data comes out. So this is my approach to MRD guided care. So number one, for most adverse risk patients, I recommend upfront transplant in CR if these patients are fit. For patients with high risk ELN, the relapse risk is high and MRD often remains detectable. So I really try to anticipate the need of post-transplant strategies, ideally in the context of a clinical trial. For favorable risk patients with persistent or recurrent MRD, it depends. If they become MRD negative after additional therapy and are borderline fit, I'm very comfortable with a watchful wait and close MRD monitoring if possible. And I think that's the one part that is challenging. If these patients go back to their referring doc, we need to make sure that we have a close communication and close MRD monitoring is done. Allo transplant is, of course, still an option, especially if they have a suitable donor and they don't clear their MRD. In intermediate risk AML, I typically recommend transplant in CR1 for suitable patients. But for MRD negative patients who are borderline fit, surveillance might be reasonable. For MRD positive patients, additional therapy can be considered on a case-by-case basis. When it comes to the question of eradicating MRD before transplant, I do consider it, but I wouldn't delay transplant just to achieve MRD negativity. We all know that outcomes are better if you clear it, but that's not always possible, especially for high-risk patients. And losing the window for transplantation is something that has happened to many of us. So great if it happens, but we don't sit and wait for it if the transplant timing is right. Conditioning intensity based on MRD, and to that I'll say conditioning intensity does make a difference, definitely. So for MRD positive patients who are fit, I really try to ablate if possible. For patients who are not fit, I consider intensified rig. If the patient is able to tolerate, I try to incorporate melphalan, or we try to incorporate novel treatments, ideally on the context of a trial. And finally, in my day-to-day practice, I'd use NGS when available and try to interpret the results in context. The pre-measure study supports its utility, but I think it's important to acknowledge the applicability, timing, and standardization still has a long way to go. This is my contact information. If anyone is interested in exchanging ideas or asking questions after this talk. And I want to acknowledge the work of my colleagues at the University of Miami, as well as the team behind the pre-measure and the measure trials at the NMDP. And I'm also grateful for the institutional support of our AML IIT. And of course, I want to thank the Saudi Society of Transplantation and Cell Therapy for this kind invitation. And of course, all of you for joining me today. And I'll be happy to take any questions.